Sir, you can start the session.
Good evening, everyone, and I thank you all for taking out time to join today's important interactive discussion, which is aimed at understanding the disease, the various questions that most of our patients have about this illness, bit of uncertainties they have, and how we as panelists can help navigate through your questions. So initially, we would have some questions that we would discuss with the panelists as questions, and then based on your questions and your queries that you can post on the chat box or on the question, we will also take them and discuss with our panelists as well. So today evening, we are joined by very senior neurology colleagues from across the country, and we hope that we shall be able to interactively discuss the different facets of this disease and the queries that most of you may have. So on behalf of the Indian Academy of Neurology and the autoimmune subsection of the Indian Academy of Neurology, me and my colleague Dr. Netravati from NIMHANS welcome you all to this interactive session. We have with us our very senior mentor and colleague, Professor Singhal. Most of you know from Mumbai. We have Dr. Tapas Kumar Banerjee from Kolkata, Professor S.P. Gorti from Pune, Professor Dheeraj Kurana from PGI Chandigarh, Dr. Rauf Asimi from SKIMS Kashmir, Dr. Shripad Pujari from Pune, and Professor Shruti Nair from Sri Chitra Institute, Trivandrum, and Dr. Thomas Matthew from St. John's, Bangalore. All the colleagues are actively involved in the care and research for patients with MS. With this, I hand over to my colleague, Dr. Netravati, to start the session and invite our colleagues to participate. Thank you very much.
A very good evening, everyone. I thank the IAN, Dr. Debashish, Dr. Yominakshi Sunjan, for giving us this opportunity to start this World MS Day with a bang, with all the neurologists here who are going to address most of the questions which most of the patients or people with MS may have. So at the most, I would request Professor Bhimsen Singhal to talk to us on importance of World MS Day, and then we shall begin the panel discussion. Sir, over to you, sir.
Thank you, Netravati, and thank you, Dr. Rohit Bhatia, for inviting me to join the session and to learn. I think the World MS Day is very celebrated all over to increase the awareness of multiple sclerosis in the society so that whenever they have a symptom, they can approach the doctor and take the right treatment. It is also to answer the questions and have various sessions all over the world so that, as Dr. Rohit Bhatia said, we understand more about the disease, the treatment available, and what can be done and what cannot be done. I think there's always a hope because I find that in the various meetings which are held all over the world, particularly the ACTRIMS and also the various such organizations all over the world, lot is discussed in the field of multiple sclerosis, and I think we are finding newer and newer therapies. Say 25 or 30 years ago, we had no treatment. Even the awareness was less. Now we have some insight into what happens in this. We understand the pathology of the disease. We also understand how the drug is initiated and how the disease progresses and how the disability can be reduced or prevented, relapses can be prevented, and how the disability can also be reduced. So we have various means and methods, which I think the panelists will discuss as the time goes on. But the importance of World MS Day really is to increase the awareness and to discuss the various aspects of multiple sclerosis. I think we can perhaps, Netravati, take it over so that we can move forward about this illness.
Thank you, sir. Thank you for blessing us to start this World MS Day webinar. As we go through the panel discussion, we'll also be taking few questions from the audience. I request the attendees to post their questions into the chat box or into the Q&A session so that it can be addressed. So before we begin, let us start with our first question to Dr. Dheeraj Purana. Most of the time, we know that especially in India, there are many other demyelinating disorders. And many times it becomes difficult to make out as to what is a perfect diagnosis. So Dr. Dheeraj, how do you diagnose multiple sclerosis?
Good evening, everyone, and thank you, Netra, for the question. I think that's extremely important because the first step to identifying multiple sclerosis is to reach the diagnosis and to confirm the fact that someone is indeed having MS, because till the time we are not sure that this is MS, and this happens quite a few times, the treatment may get delayed. So it is highly imperative that we take recourse to the right measures and the right ways to diagnose. So, how do you diagnose? The question that you've put in. Well, I would put it as a clinical one, as a clinical suspicion, and a high degree of a clinical, I would say, a low threshold should be there by physicians to look into the possibilities of somebody having MS. So usually the clinical scenario matters a lot. More commonly, it is seen in younger patients, younger people, younger and especially women. We know it is at least 2 to 3 times more common in women than in males. So any young woman presenting with neurological problems, commonly like losing sight from one of the eyes or even both eyes, uncommonly, or having weakness of one side of the body, or numbness. Usually it is not very severe weakness. These may even be milder symptoms like numbness of one arm, the leg, or both the legs, and weakness and numbness, both these things. So anything which may suggest involvement of the neurological, any axis of the neurological system should trigger a search for anything like MS. And we do know that this may come time and again. So a history is extremely important. So sometimes people present to us that they had mild numbness of the hand or arm, maybe sometimes back, a month back, or sorry, a year back, or a couple of years back, and that got okay on its own. So that history is extremely important to find out, did somebody have that symptom anytime in the past and is now having maybe another symptom, but or even the same symptom. So that should be the first trigger point of the person, even as a person, as a patient, or as somebody who's suffering from that. He or she should consider that this may be MS. I'm not saying this is confirmed, but then they should seek help or seek opinion from a specialist or even a physician. So it's always good to reach a physician, to reach a neurophysician and right in the beginning. But even if the physician has a high index of suspicion, he or she, the patient, should undergo an MRI. That is the biggest confirmatory test that we have, because once the signs match, the MRI should be done immediately. And the MRI usually helps us in confirming the diagnosis by its characteristic appearance on both the brain and the spinal cord. So brain spinal cord MRI with a contrast should be carried out with localization of the characteristic findings on the MRI, and additional tests, which of course the physician does order, that has to be carried out. Those have to be carried out, specifically the spinal tap or the CSF test, which helps us in confirming, as well as has quite significant value in prognostication of MS. The other tests, of course, are not diagnostic, but we should do a certain thing. A certain battery of tests should be carried out to rule out other possibilities. But chief amongst all of these, I would say, is a very high level of index of suspicion in terms of the clinical features one presents with. And of course, the diagnostic gold standard rests upon the MRI, which one should carry on.
Thank you, Dr. Dheeraj. So you definitely nicely based as to how much clinical examination is also important, because many times we see that people just take one MRI report and come and they tell that they have this disorder. So very, very true. We should always see what is the clinical symptom which is there and then try to correlate with the investigation and then make a diagnosis. So
And I
before
think the
we take
history of a past
history,
event is extremely
yeah.
important because sometimes that gets missed. So
Mm.
one has to look back and really be inquisitive to the patient.
Yes.
Did they ever have something like that? Because, as far as the criteria goes, although now we can even we can diagnose at the first attack, but having two attacks makes things very easy, and we can reach a confirmatory diagnosis by the history of a previous attack.
Yes. Yes. Thank you, Dr. Dheeraj. We'll go to the next question. So Dr. Dheeraj spoke so many things on the visible symptoms, and we know now MS is something about invisible symptoms. There could be fatigue, there could be so many cognitive behavioral changes. Over to you, Shruti, about how cognition, especially the cognition being affected in multiple sclerosis.
Thank you, Dr. Netra, for the question, and thank you, IAN, for inviting me. So the cognition is cognition of what we generally call as memory problems or forgetfulness is something which is not always seen as a forefront problem in MS, because most of us focus on the problems like weakness or visual problems or numbness. But on the other side, that is the one symptom that can produce a lot of symptoms or dose of dysfunction to the patient, in the sense that there is more difficulty in finding a job or more difficulty in carrying out the day-to-day function. So in general, they experience a different type of memory problems from what we usually hear, like in Alzheimer's and all. People come with problems of forgetting things, misplacing things and all. But in MS, what is mostly seen is that people have difficulty in multitasking or in processing information. They take a longer time to understand things or to grasp the ideas compared to what they used to do when they didn't have the disease or when they compare themselves to other people of their age. And there is also significant problems with learning new things. So these are possibly the most important cognitive problems that are found in MS. Surprisingly, if you do a very detailed and MS specific test, you would find that more than 50% of patients would have it. So the studies call it between 40 and 65% of people have some kind of a mild or some moderate cognitive problems in MS. Now, how do we tackle it? So I think that the general population can tackle it by keeping their brain healthy. So the amount of reserve that you have is quite important. So keep the brain healthy by following a good diet, having a balanced, macronutrient profile, uh, doing regular exercise, and generally being socially interactive and getting your, knowledge up. That helps with, problems with cognition, and avoiding smoking and other vascular risk problems like alcoholism and everything also helps with keeping your brain healthy. In those who really have MS, the problem is not always directly proportionate to the how much other disability you have. But even when you have MS, your major focus should be on getting yourself healthier, doing more exercise. That is one thing which has been shown to improve cognition. 25 to 30 minutes of aerobic exercise has been shown to be as effective as doing some mental exercises. Medicines do not help to the extent like they help in other problems with memory issues. And another important thing is other factors which contribute to what looks like memory problems, which include depression, having fatigue, and anxiety. And if the patients have any of those problems, that should also be tackled effectively, and including that will include sleep problems as well. So just enumerating them, the first thing is to keep your brain as healthy as possible. This is for patients as well as those who are not patients. And then doing exercise very regularly, some 25 to 30 minutes of aerobic exercise, tackling other problems like sleep disturbances, depression, anxiety, and fatigue, which can contribute to cognitive problems. And that would be, I suppose, the way to deal with cognition.
Thank you, Shruti. So definitely it is not simple like what we see in other dementia or other disorders. It is very subtle, very minimally initially affecting, and eventually may be more, especially in progressive form. We have now Dr. Debashish Chaudhary, our IN president, who has joined us. He was a bit late. Sir, could you give us a welcome message before we can go ahead with the panel discussion?
Yeah. So good afternoon, everybody, and I really apologize because I got held up while traveling back home. So, first of all, congratulations to the subsection, and all of you are doing excellent work. And as we can, as you can appreciate, in the last 1 year's time, the subsection activities of various subsections have increased tremendously. And I think that the autoimmune subsection is going ahead, and I think Dr. Rohit has planned a lot of activities year ahead. And this, of course, is the first step, but we would like to engage with the general public and the laypersons to make them aware. And also, a lot of educational programs need to be done, taking the GPs and CPs into consideration, because they are our referral, manpower, and if they don't send the patients with even suspicion, then these patients actually roam around and lose a lot of time reaching to the specialists. And of course, I think you should also think of engaging in some, and enhancing some of the basic research aspects in autoimmune disorders. And I think India has the potential to do a lot of basic research in these disorders. And I think you can be the, key resource people to facilitate those kind of research, either by the, kind of ICMR projects or in-house projects, or sometimes you can also talk to the academy. And academy, I'm thinking of creating some degree of fund for promoting further research from IN also. So that is very important thing, that we should have our own data, not only the clinical data, but basic data for all the neurological disorders, including the autoimmune section. And lastly, I think that we need to also consolidate. So this has been proposed by me, and we should consolidate all the publications that are happening from India on various subsections, on the subspecialty interest, so that we can create a repository of these articles, at least their, the abstracts, so that any researcher in India who wants to know about the Indian, context of that research can easily access that. Now, what you have to do, you have to go to either PubMed, or you have to Google, or some other, search engine to find out those Indian data. But if we can have a repository of our own, and it can be a kind of a PubMed India kind of a thing, so that we can have all the neurological, publications that are arising from India in one place, so that people have a good access and easy access to that. So I think autoimmune section should think about that and work on that. And I really congratulate you for this effort, and I wish you all the very best. Thank you.
Thank you, sir.
Okay, taking the discussion forward, we've talked a bit about diagnosis, with Dheeraj mentioned, and we'll take some questions during the end, plus we will take them intermittently. I'll just take from where Shruti left, and Shripad, if you can talk about, like Shruti did mention about the, the subclinical symptoms which are not very apparent. And I think she talked about cognition as a whole, as a large domain. But there are people who also have issues like behavior and anxiety, and also feel low or, dysthymic, or left out of the society, as if, something has seriously struck them. So, I mean, would you like to just talk about this kind of behavioral anxiety, depression that patients can feel, and, what can be done about it, and how positive they can live, knowing that in today's era, this is a very well treatable illness? Can you please unmute, Shripad?
Thank you, Dr. Bhatia. I also thank IN for giving me the opportunity to share my views. And Dr. Bhatia has raised a very important question. It pertains to subtleties of behavior, cognition, anxiety, and other areas. So prima facie, because of MS itself, because of the demyelination, the loss of connections itself brings them at a lower level of cognition, as Dr. Nair herself said, and that adds to their level of anxiety because of reduced level of performance in day-to-day activities, both in their workplace as well as in the family life. And that creates a secondary anxiety issues. They are unable to cope with their day-to-day activities. Again, behavior-wise as well, because of impaired functioning, plus slowly progressive nature in the course of disease, they would have depression, panic states, low mood, and low performance in general. Physical symptoms also add to this impaired mentation as a whole. The way to address these issues are non-medical and certain drug therapies. And under non-medical, as neurologists, we need to give some suggestions such as taking intermittent rest, naps, short naps in between their work periods, which would help them to deal with their fatigue and irritability and enhance their day-to-day performance. Then cognitive behavior therapy also is helpful, suggestion therapy. And then in the end, drugs such as benzodiazepines and certain antidepressant drugs, and if necessary, low dose atypical antipsychotic drugs only if they are indicated for a particular type of behavior issues, they can be prescribed, but mainly benzodiazepines such as clonazepam and selective serotonin receptor inhibitors and other antidepressants may also be helpful. There are trials on certain drugs to address sleep disturbances as well. They can also be prescribed.
Thank you, Dr. Shripad, for your overview about this whole perspective. The one positive point I would like to mention from where Dr. Shripad was also suggesting is that please have a healthy lifestyle as a
Yes.
part of this. If you feel any uncertainty or any concerns about your treatment, monitoring, please discuss with your doctors openly and be very frank about whatever you feel. Sometimes it does happen in busy clinics that we are not able to, interact with that much need, but as far as possible, doctors try to answer most of the questions, especially because we understand that you have many of them. And if you really feel low and if there is an indication for treatment, then there are medications available to help you navigate through that issue also. So there is, and on a positive note, I mean, in today's era, as I said, majority of you should not feel that concern, especially in the early phase of the disease, that your disease is here to be well taken care of and well treated as well. Now, from that note, I move on to more specific, and there are more questions also in the question answer box that we will take as a parallel to this. So, Dr. Tapas, a lot of times what happens is that when patients meet the doctors and when the case of a patient is being discussed and there is a communication, and in today's world, there are so many disease-modifying treatments available. So would you like to point about the factors that will help you decide to start treatment in a patient when he presents to you for the first time? And are there any specific choices that should be made depending on how the disease profile is? We have questions like, how do we decide on starting disease-modifying treatment? I'm taking dimethyl fumarate 240 milligram. There are these subtle issues. So there are few of these questions, and there are specific monoclonal questions that we will take as we discuss about monoclonal antibody drugs specifically. But if you can just highlight upon how we decide on the treatment, when do we decide, and how we navigate through the choices.
Right. Thank you, Rohit. This is a very important question. I think the trend now is to capture the disease and start treatment as early as possible, because we now know that if we treat them early, because the inflammation part is the first thing that is happening in these patients. So if we treat them early, we have our tools to actually suppress or modulate the inflammation part. The degeneration part comes a little bit later, but if we capture the disease early and treat the inflammation early, I think we can give a much better outcome in the long run for the patient. So trend now is to be aware of the fact of all the different types of clinical presentations of this case, and which happens in this particular age group where we strongly suspect multiple sclerosis is there. You do the proper investigations, and if it is established that there is a case of multiple sclerosis, even if it's the first attack, which we say the clinically isolated syndrome, we have to keep it in mind. You have to start the treatment. There are some cases, incidental findings. They never had any attack, but radiologically, we find very classical features of multiple sclerosis. What you now say radiologically active syndrome, radiologically isolated syndrome, sorry. And there also people are thinking whether to start treatment. But the fact is, in the first event of multiple sclerosis, I think we have this McDonald 2017 criteria where you can have a very high kind of, we can say more definitely that this is the first event of a case of multiple sclerosis. Then we should start treatment there. Now, when you start treatment, you have to share the different pros and cons of the various disease-modifying drugs with the patient and see what is their thinking about it. Suppose we have a patient here who is a newly married woman who is going to conceive very soon. Now, in that sort of circumstances, would you start disease-modifying drugs? I think all drugs can have some deleterious effect in pregnancy. So if it is a very mild kind of attack the patient has and the patient is going to conceive, we can defer treatment in those cases till the pregnancy part is over, the childbirth has happened, and then you can initiate treatment. But if you find, and what kind of medicine are you going to give? People are a little bit needle phobic, so you can suggest the treatment with parenteral therapy in these patients. Many patients, or most of the patients, will say no, will not go for injection treatment, will go for oral therapies. Now, if we feel that the patient has a high load of the lesions in the brain, had a very pronounced attack, and is the sort of oligoclonal band is strongly positive, then you should think about whether to start the patient on the high efficacy therapy, because at the end of the day, in the long run, the high efficacy therapies are much better than the platform therapies. If you think it's a very mild attack, the lesion load is low, you can go for the platform therapies, which are moderate efficacy therapies, and oral therapies are the choice for the patients. For the oral therapies, teriflunomide is something we should not start on a young woman who is soon conceived. We probably will go for the fumarates. For if you think of high efficacy therapies, we earlier on used to have natalizumab, a very powerful therapy, or alemtuzumab. Some people have opted for it. I think with the advent of these B-cell depleter therapies, the side effect profile has become much more favorable. And so if the patient agrees to it, if you think this is a case of multiple sclerosis, which may have bad attacks in near future, we can start off with the high efficacy therapies with the B-cell depleted therapies. We have a whole list of B-cell depleted therapies: rituximab, ofatumumab, ocrelizumab. So again, you discuss with the patients and find what therapy the patient is going to have.
Thank you, sir. Thank you for giving an overview about different treatments available. I think it's a big armamentarium. And as you rightly said, the presentation, the disease burden, how we perceive, how the patient understands, I think there are a lot of factors that go in making a decision for the right or preferred DMT. However, like there is a question, someone said, I read about a drug, Plegridy, and is it a better or more advanced medicine, and is it useful in RRMS? Would you like to mention something about it, sir?
Yeah, Plegridy, I mean, the trend is to go for the oral therapies now for the patients, but Plegridy has been given this option. It was a little bit more pricey than the other interferons. The thing is, it is probably less painful, or the patients feel more comfortable when taking Plegridy. It can be given at 2 weeks interval instead of 1 week. If the patient wants that, we can definitely give that treatment option to the patient.
Yeah, so as a clarification, it is not something that is superior to the usual platform agents. It is one of the previous drugs listed in the platform therapy, and as a matter of choice, if you prefer to take low frequency therapy, like not a daily therapy, and you are someone who prefers to be on an intermittent therapy and on a very early phase of the disease and early diagnosis, and you are willing to take an injectable drug which potentially can cause fever and body aches and flu-like symptoms on the day you take it, which of course can be pre-medicated, you can definitely be offered as a treatment. So it's one of the drugs available for treatment. But as Dr. Tapas mentioned, majority of the subjects would prefer to take oral these days because of more comfort. Moving from there, and as we talked about more highly effective treatments, drugs which are thought to be highly effective, of course, include fingolimod, they include natalizumab, and there are people who have listed drugs like ocrelizumab, natalizumab, alemtuzumab, ofatumumab, and so on. Dr. Gorthi, many times when we treat these patients with these highly effective agents, there's a concern that immunosuppression would happen, so they are navigated through a decision making for pre-check and pre-listing of the checklist as to how we navigate and decision to give vaccination prior to the start of the disease modifying treatment. And sometimes there are questions as to, can I take a particular vaccine when I'm on these agents? So would you like to tell what we do in practice prior to start these treatments and how we monitor these patients? And of course, about the different monoclonals, we will have a separate questions about there being one being better than the other, but it is about the pre-decision that we take when we are starting these patients, especially from vaccination strategies.
So actually it depends on what type of treatment which we're going to they're on. And before I answer that, I thank IIN for giving me this opportunity, and of course autoimmune cyst subsection. So basically we started these therapies when somewhere around late 90s with Rebif, when interferon started coming up, and we have been learning about this disease and introducing more and more effective therapies. Whether it is a platform therapy of interferon, whether it is a Rebif or it's Avonex, or it's a highly active natalizumab. So actually there is, as such, when in my experience, there is no contraindication for any of the vaccines which can happen. And what are the viral diseases which we have encountered, or herpes zoster viral infections, recurrent infections. So there is a theory that you can get a zoster vaccination done, and some people advocate that. Otherwise, I in my personal experience, we never had any problem with any of these vaccines, and they can be vaccinated even in COVID. Also, the vaccination has been continued while patients are on immunomodulatory therapy with highly active. So I think not much can be said about the vaccination in my experience.
So thank you, Dr. Gorthi. So just as an add-on point that for specific immunomodulators like monoclonal antibodies like ocrelizumab or alemtuzumab, to some extent, even with rituximab, there is a preference, and in some it is a clear guideline that we need to pre-vaccinate. So what most of us will do is check your viral markers, your presence of hepatitis B immunity, immunity to chicken pox, which is a varicella. And based on that, a relative decision whether you need to be vaccinated pre the start of treatment is taken. For some drugs, it is a mandate that we have to vaccinate. For rituximab, generally we prefer to vaccinate. Sometimes it may so happen that the drug needs to be started on high priority. So we can, we miss the vaccination part and we start directly. The other important thing is if you have any illness during the course that you are on immunosuppression, you must discuss with your treating physician before you take a decision to take any vaccination. So must consult your doctor. And especially live attenuated vaccines like chickenpox vaccine and others are strictly contraindicated while you're on immunosuppression till that is clarified from your treating physician and the infectious disease specialist. So our suggestion to all the members, as Dr. Gorthi said, most of the killed vaccine or recombinant are not contraindicated, but they have a timeline pre and during the treatment, but must consult your doctor before taking a decision. So the next question I will discuss and move on to Netra to follow the rest is that now that we are discussing about these strategies of vaccination and talking about these drugs, Dr. Thomas, are you there?
I'm there, Rohit. I'm right.
Okay. So there are a lot of questions in the chat box also and about monoclonal antibodies, especially ocrelizumab. Some people have talked about rituximab, and there are questions related to safety. There are questions related to about these drugs. So could you please navigate the attendees through what are the different monoclonal antibodies and how do we choose them? Is one better than the other? And a lot of people come with this choice about ocrelizumab, but then they feel they can't afford. So what are the options in such patients?
Thank you, Rohit, Netra, Ian, for having a wonderful meeting on MS. And as Rohit has currently directed the question on monoclonal antibodies. So in India, as you all know, affordability is a big issue for most of our patients. But we have all treatments available for MS patients in India. We have alemtuzumab, we have ocrelizumab now, we have rituximab, we have ofatumumab. So we have all the monoclonal available for patients. But most of us started our journey with rituximab, so we have the maximum experience with rituximab. So like Netra and most of us agree that the time for treating MS is early in the disease. So studies have shown that those who are lucky to get the right treatment, the right time, which may be within 2 years, maybe, or I would say as early as possible. If you are on the right treatment, most likely a highly efficacy therapy like a B-cell therapy, rituximab or an adherence, or one of those treatments, your chance of having a less disability or disability-free is high. And your chance of going into a secondary progressive MS is much less if you are on a highly effective therapy. How to choose whether you are a candidate for highly effective therapy? It's very tricky because sometimes we can underestimate MS based on the number of lesions and things like that. So most of us now, as a trend, we may go for a high efficacy therapy if you are diagnosed as MS, because many times when we decide whether it is the type of MS is highly aggressive or not, over time the time is lost. So they found that the time is very important, how early you start. So why the time you are reached after 10 years, you decide that you find that the disease behaving in a different way, you are developing a walking difficulty or a bladder symptom or a cognitive problem, and it is progressing, then you have already lost the time. So it's very tricky. So for people, I think you should not take decisions yourself. You should meet your neurologist, MS specialist, have a discussion with people, and every 6 months we may also change the way we think with the medicines we start. So the field is so evolving that we should keep discussing with the MS specialist and choose the right therapy. As of now, rituximab is easily affordable for most of the Indian patients. So none of the MS patients should leave taking a good therapy and go to alternative therapies and lose their valuable time. And then we have many factors which may help in choosing, like the number of lesions, where the lesion is it in the brain stem, you have bladder symptoms, you have cognitive symptoms, you have brain atrophy, if there is a serum neurofilament assay available, the elevated neurofilament levels. So most of these things help us to judge that the MS is bad or highly aggressive, and then there is no question, start the highly effective treatment. But some patients in the beginning, we think they have only 1 or 2 lesions, they're disease, there are mild symptoms, you want to wait, but then carefully wait, do the scans, do the clinical examination, do the EDSS score, so that we pick up the right time and treat with the right treatment. Hope, Rohit, I have answered some part of your question.
Yeah, so there's a question which you can answer so that Netra can move to the next part. Is about this issue about how many times I should be taking rituximab. I'm on rituximab, how many doses I need to take. So
yeah, so this is that's why I told our idea, our knowledge, our concept evolves. So the conventional teaching is that you have to take lifetime, you have to take long term, because you don't have a cure for MS as of now. When you are either you're on a bone marrow transplantation, question is different, but you're on a highly effective immune therapy, it has to continue because MS is a relapsing disease and it over time progresses. So our aim is to continue the treatment. But there are exceptions to the rules later, but I think officially nobody should just stop the treatment after 2 years or 3 years. Then there is a high chance that you may relapse the disease and you go for secondary progress. So as of now, please continue the treatment. And usual regimen, what we give rituximab, we may give a 1 gram dose and then 500 mg every 6 months. But we have some lineage in that. If your CD19 20 is 0, you are doing very well, then we face the infections. Otherwise, also, if you're doing bad, you're getting relapse, you may hike up the dose of rituximab because this is a empirical regimen for rituximab, unlike ocrelizumab, where we give 600 mg every 6 months, and rituximab, we have a little leverage to go this way and that way. But by and large, you have to be on treatment, and stopping treatment is not usually advisable. But if anybody stops, or you're doing very well and you stops, be on follow-up so that you don't miss that transition from RRMS to the SPMS. So we have to be careful when you do that, but be on follow-up and do the clinical evaluation, do the MRI scans, and if neurofilament possible, please do that and follow up.
Thank you, Dr. Thomas, for bringing up about the different type of dosages in rituximab, because most of the time, many people are confused, especially with the dosages. Now I would like to request Dr. Rauf to discuss. Many of us have already discussed on the different type of medications which have to be given, the need for early treatment and continuation. So one of the questions which most of the patients ask is, when do we stop? Or sometimes we also take a decision that this patient is not responding to this medication, let me switch. So kindly tell us, what are the reasons we switch, and are there any reasons to stop?
Thank you, ma'am. Yeah, thank you, ma'am, for inviting me. And thanks, Professor Rohit, sir, for inviting me on this panel. Actually, we see a lot of MS patients here. In fact, I started diagnosing only after coming back from PGI. Chandigarh. Once I started, there was no concept of MS here that time, and we started diagnosing. Those days, it's in 2004. So at that time, we used to give steroids, and there was just Evonex available that time. Since that time, the therapies have been added. So I have seen some patients with benign MS. Like initially, we used to have only steroids, and patient would not even afford Evonex or Rebif that time. So I would see that some of these patients would not relapse for 5 years or 6 years. And after 6 years, 7 years, they would relapse multiple times in next 3 or 4 years. So, and there were few patients wherein the relapse rate was very high. they would relapse every year once or twice. So there is, I think, wherein we thought that there is this MS disease is different in different people. The presentation is different. Even if it was RRMS, the number of relapses and frequency of relapses were quite different in different people. Whether that has something to do with the genetics of the MS or the disease itself, that was one point. Second, the treatment part. Once we start, we usually start because the cost is the issue at this place. Our patients are not insured also, so they have to pay from the pocket. So what we do is usually we start them on oral agents, whether it's teriflunomide or DMF. So most of these patients do well. But yes, there is a switch off from DMF to teriflunomide also because of some side effects or vice versa. Then there are few progressive patients wherein we have tried rituximab because people cannot afford ocrelizumab. We had given choice of Ocrevus to one or two patients, but they could not afford it. So with rituximab, I could see that there are around 4 or 5 patients of ours who are on rituximab, the progressive ones, who are doing well on this medication. And young females, they are there for last now 3 years, who have received. See, again, we are not giving 6 monthly. We do anti-CD19 and CD20. And if the CD20, if the count is very low, then we just wait for some time. Again, the issue of affordability and or toxicity. So accordingly, we give once or twice a year, we give rituximab, and we maintain them on that. I don't have any experience of using natalizumab or ocrelizumab here because of the, again, affordability of the patients. So regarding the switch, if a patient is not responding despite being on oral agents, and we go for MRI and we see the new lesions appearing on MRI, these are the patients wherein we should definitely try for aggressive therapies like natalizumab or ocrelizumab. Wherein some of these patients, then they go to higher centers for receiving the other treatments. That's all. That's my experience in this group of patients.
Thank you, Dr. Rao. And also sometimes what happens is many of the patients will be either clinically doing well or clinically they may worsen on a disease modifying agent. So that is the time we have to switch over to a different disease modifying agent, which should be slightly better. We actually have the platform therapy and then the injectables, which are supposed to be for highly active. So that is the time we actually switch over. The other question was about stopping of disease modifying agent. I think both Thomas and you, both of you have already mentioned that there is
regarding stopping, there's no, it has been already told by other panelists that for time, it has to be indefinite.
Yes.
It has to be indefinite.
Medications are usually indefinite. We don't stop, except maybe sometimes if they have stabilized during pregnancy. And that also if they have stabilized. Otherwise, we don't stop medications.
Right.
One of the questions from the audience is from Ms. Shubhra. She talks on, I'm stable on rituximab since 2021. Should I still have MRI scans to monitor disease activity? Dr. Dheeraj, would you like to take this question?
So if that's again, we have over the years, we have modified our protocols for repeated imaging. So currently, like the usual dictum, which has always been recommended, was to get it done annually. So annual MRIs were recommended all these years. But now, what has been seen is if the disease is quiescent, it is completely stable. Patients are not getting any new symptoms. We may even have longer gaps for imaging. So, for example, we in our current practice, what I do is, if the disease has been stable for at least over 2 to 3 years with no relapse, no new symptom, we can delay it for up to 2 years. It's feasible to even delay up to 2 years, unless there is an intervening symptom which comes in. So we may prolong it for every 2 years, and annually can be avoided in case of a stable disease.
Yes, thank you. Shruti, Thomas did discuss about rituximab efficacy and usage and dosages. But now we also have many other monoclonals and CD20 therapies which have come in the forefront. So could you tell us about ocrelizumab, which is the new monoclonal which is there in the country now?
Thank you. So, ocrelizumab has been something I think patients and the doctors have both looked forward to for coming in India. It has been available outside for last 7 years, and it has been marketed in India since December 2023. So, my experience with ocrelizumab is confined to primary progressive MS. We know that it is effective in both relapsing forms of MS as well as the only drug which has been approved for the progressive primary progressive MS. So it is too soon for me to say how the outcome is based on my patients. I've given it for 2, and one patient has come back after 3 months telling that there is an improvement. Although objectively there is very little change, but she feels she is better. The second patient says that he is slightly worse. So whatever problem he had, which had been going on for the last 1.5 years, that he has had an upper limb weakness or a hand weakness, that has been continuing even after giving ocrelizumab. So what do we really know about ocrelizumab and progressive MS is that it is probably one of the agents which is in progression, but it is more effective when you have many new lesions and on the when the person itself is a person with MS is younger than 40 years of age. It is far less effective if the patient is older and there are no active lesions at all in the MRI. And another thing we need to keep in mind is that when we give medicines for progression, we may not get an effect immediately because there is always a therapeutic lag. So progression occurs as a secondary to something which has happened earlier. So there is an ongoing damage in areas where there have been lesions, and overall problems in MS lead on to certain degenerative changes. So we may not get an impact immediately, and that should not take us away from the possibility that the patient may stabilize after 1 or 2 years. So ocrelizumab is highly effective in relapsing MS. I'm not talking about it because it is as good as rituximab and any other monoclonal antibody, and it has to be repeated every 6 months as an infusion. It's quite costly. It costs approximately 5 to 5 lakhs for the treatment every year. But as far as progressive MS is concerned, it's a ray of hope for us. And I'm hoping that if we initiate progressive MS patients early enough around ocrelizumab, we may have a good outcome. Although we don't have evidence to that effect, I believe that rituximab may also work in a similar fashion. So we can use, I suppose, rituximab in a similar fashion to ocrelizumab as well. That's it. I hope I've answered the question.
Thank you, Shruti. Even my experience I've had with 3 SPMS patients, and it has been quite good. Now I hand over to Dr. Rohit Bhatia to take over.
So we will take some questions intermittently from the pool, and once we finish some of the important relevant, then we will just take on to the questions from the audience. So Dr. Gorti, there is one question from one of the attendees, is that I was administered steroids in the initial part when I was diagnosed. And probably she's talking about the first event, the relapse onset. And the question is, what is the use of steroids? In other words, so how do we treat a relapse and why steroids are important during the treatment?
So basically, the treatments are 2 aspects in MS. Whenever an acute attack comes, to tackle the inflammation, we use steroid. That's called symptomatic treatment. It's not mainly a disease-modifying therapy. It is to be given as a intravenous dose of methylprednisolone for 5 days, followed by tapering dose for 2 weeks to 3 weeks. And after that, the initial the attack subsides, then you have to start on the disease-modifying therapy. And that could depend on what type of endophenotype you are likely to encounter. So certain indications are there to what type of treatments we should take. If CSF has got some cell count and raised oligoclonal bands, and there is a lot of guide enhancement lesions, then we may have to go to highly active therapies like natalizumab, which I have major experience, and ocrelizumab. Now, if you have another phenotype that's called E1 phenotype, where you have right from beginning, there is a cognitive impairment, as Netra was saying, and music cognition less than 20, and all these things will tell that it's a degenerative or right from beginning structural damage is there. So then you will have to go for a different type of therapies. Otherwise, if these two are not there, then we'll go on to, we'll treat the acute attack and decide on disease modifying therapy and follow up the case, as Dheeraj said, once in a year or 6 months an MRI, and look for any lesions. It's very difficult to extrapolate the studies onto individual patient, and we have to look for a precision based medicine then, because as you must all know that all these studies have annualized relapse rate, which is about a group of patients. So to say that a patient, whether how he reacts, how he improves, is very difficult, but we can only hope that because there are large number of studies and large patients have been treated, number of attacks have been reduced by these therapies, we hope that can be extrapolated to the individual patient. So the best we have is, as Thomas was saying, that we have steroids, and Dr. Singhal also said, initially in 70s and early 80s, we got nothing but except steroids, which we were treating, which we use. And then came Imuron also, then metoxantrone. These are immunomodulating therapies. But the symptomatic treatment is with steroids, and that is the first therapy that a patient, whenever it comes, we have to give.
Thank you, Dr. Gorti. So to answer this question in nutshell is that when you get a breakthrough event and your doctor adjudicates that it looks like a relapse and not a fluctuation, and it is generally causing difficulty to the patient, intravenous steroids for 3 to 5 days is a treatment of choice, and it's a standard way to treat relapse. There is a bit of a, I would say, debate, not really a debate, but over the years, people have felt whether you should give follow-up steroids for 2 weeks, 3 weeks on tapering, which you used to do. We still, a lot of us within the community feel that we should give follow-up steroid so that we can give a persistent anti-inflammatory drug so that it reduces the inflammation in your brain and helps the brain's myelin to recover back to its near original way. And in some, if it's a mild event or it's a steroid responsive event in the first 5 days, some people feel that maybe oral steroids follow-up is not really required. If you have a more severe relapse where you are not showing improvement with steroids, especially for people with NMO, MOG, but to some extent even for MS, you can be given an option of something called plasmapheresis, which generally we wait for about a week, 2 weeks to see the response, although the response can be variable and our decisions can be preemptive or based on a follow-up of 2 to 4 weeks. And if that is not possible or that cannot be given, there is a very small evidence to use intravenous immunoglobulin, but more evidence for use in MOGAD and to some extent in NMO. So your patient treatment will be decided by your doctor, as Dr. Gorti mentioned, and the severity of the relapse will dictate the add-on treatments even beyond just simple IV steroids. From there, I would now request Netra to answer an important question. Women with MS do pose a challenge and they have a very important concern, especially related to pregnancy. So, pregnancy when they have been diagnosed and pregnancy once they are on treatment. So there are like these two components that we come across. So would you like to highlight based on your experience and the science as to treatment of women subjects with multiple sclerosis?
Thank you, Rohit. Yes, we may have two case scenarios where a person is planning for a family, and the other scenario would be a person who is already on treatment wants to consider family. So considering the first scenario where a person is married but not yet started her family. So what actually needs to be done is we need to control the multiple sclerosis first, even before they plan for their pregnancy. That is a very most important. There is a myth that we should not give them immunosuppressants or disease modifying agent because the steroids has anyway improved them. They've come back to the baseline. They've completely improved. So why to start disease modifying agent? Why to put the body on something and then plan for family? No, that should not be done, because MS is something where apart from the inflammation, there is undergoing degenerative phase which will keep on going. So though you may not see the attack, though you may not see the inflammation, you may have the pregnancy which will go on. Later, it can come back with a bad relapse and there can also go into the progressive form. So the first thing is to control MS first. And it is advised that they are on disease modifying agent for at least 1 year, if not possible, for at least 6 months before they plan for pregnancy. So that is the first case scenario. In the other case scenario where a person is already on medication and wants to start a family, there it would be depending on what medication the person is taking. For example, relative contraindication, teriflunomide and mitoxantrone. Mitoxantrone, only few people are there now, teriflunomide. On that, it is better not to plan for pregnancy. So if you're on that, always talk to your doctor that you're planning for pregnancy so that your disease DMA is changed, and then you can plan for your pregnancy. And then when you're trying to take the disease modifying agent, it depends on what medication are there. So there is something called as a washout period. So if you're planning on interferons, glatiramer, or even the oral disease modifying agent, it is advised that you at least give 1 cycle free. That means if you're on these medication and you know that you're going to have, you're planning in the next 1 to 2 months, you have to live 1 menstrual cycle free and then plan for pregnancy. But of course, sometimes what happens beyond that 1 cycle, if you live them, there is a chance of a relapse which can happen. So if they don't want to go back, so sometimes they do not want to go back to the disease modifying agent. So during that time, we can plan to give a steroid pulse, which will go along with their menstruation cycle, so that we know that during that time they're not pregnant, as well as we're giving the steroid, which will cover them for the next 3 weeks at least. That is the other way to go. The other thing is to give medications, if they're especially highly disease activity, to give medications which can be given, and then just stop it at the time of the conception. That means when they are diagnosed as pregnant, and then give later after the delivery. After the delivery, depending on whether is their lactation, whether it is good or not, depending on that, it has to be restarted. Thank you.
Okay. Thank you, Netra. I think you have summated this whole concept about decision making related to pregnancy before conception, and while if you've been diagnosed while on medication, how to take a decision forward. So from there's one question which we can take is about, someone has asked as to how many number of months to be skipped if female patient wants to conceive undergoing rituximab treatment. Not so a quite common question in the clinic while they are on rituximab, how to plan their pregnancy.
So usually they say, initially they used to say at least 3 months, but now many studies have also shown 6 to 8 weeks is enough. That is, after the rituximab, they should not plan for pregnancy for the next 6 to 8 weeks. 6 weeks minimum, if possible 8 weeks. After that, there is a 4 months period when they can plan for their pregnancy. So that is the way, if they are on rituximab, they can plan for pregnancy. But in case they become pregnant during those 4 months, they need to inform the doctor so that adequate precautions are taken both for the mother as well as the child. But in case they have not become pregnant, so just doing a urine pregnancy test is not enough, because I've seen many times. Please do even a beta HCG. That also has to be done before pregnancy is confirmed, before the next rituximab dose is given. I've had patients where they did UPT, it was negative, so they took off the rituximab. Then after that, the beta HCG levels were increasing and they were found to be pregnant. So it's always better to do both before the next dose of rituximab is given.
Thank you, Netra. So, Dr. Shripad, there is a question which is quite, an important component of thought process with subjects with multiple sclerosis, is that what is the progress going on in research or treatments? What other treatments are in the pipeline which can help and become more specific for a potential possibility that, you've taken a treatment which is going to potentially cure you? Of course, we don't know that yet, but what is the ongoing progress about newer therapies in the pipeline and the progress on research in MS?
Yes, Yes, thank you again, Dr. Bhatia. Sometimes patients do ask this type of question. As my many other colleague speakers said, we have gone a long way in terms of improving our MS therapies, the ones we call disease modifying, which control the disease. And there was some time when we almost did not have any medicine for into inverted comma progressive MS. Now we have ocrelizumab and there is some evidence on rituximab. So the main purpose is there is this term called no evidence of disease activity. So no disease activity should be seen in the body, primarily measured clinically by two norms. The number of relapses, as Dr. Gorthi earlier mentioned, which we count, and there is this progression of the illness, even if relapses do not occur in the patient. In addition, there is a goal to prevent changes occurring in the MRI, what we call new lesions or into inverted comma plaques. And then the brain also shrinks. So all these, the aim is to stop. As of now, we have found many powerful second or third line medicines, mainly in the form of monoclonal antibodies, all my speakers said, such as ocrelizumab, natalizumab, and we've reached to a stage, and alemtuzumab, which is another powerful medicine, wherein we've reached, say, by percentage, in our studies, we have percentages where disease is controlled, say, 70 to 80%, broadly we can say, with these powerful drugs. These basically suppress the several variety of white blood cells to prevent further damage to both the myelin as well as the axons. At the next stage, what mankind and neurology fraternity is looking for, one of them is called remyelination. So we lose the insulation and whether we can bring it back. There are medicines in pipeline which have shown efficacy in bringing back the myelin that was lost during the attacks and because of the progressive nature of illness. There are also medicines that are being tried to improve day-to-day efficacy of the patient. Some of them, like there is a medicine called diaminopyridine, which improves the efficacy in day-to-day life, such as walking, may reduce the amount of fatigue that the patient suffers across the day. There are more medicines that are being tried in this area as well. Then pain is another area. We know we have found many medicines, and then recently we have a derivative of cannabis, which is also now being used in certain countries. Likewise, more medicines are being explored to tackle the symptoms such as pain, fatigue, bladder symptoms, spasms, and fluctuations and things like that. We are hoping that we will be able to try and halt the illness right much more immediately after its diagnosis by finding more and more powerful agents which prevent further loss of myelin and further loss of the whole brain itself, what we call the volume of the brain, so that patients' disease is kept at bay and patients, what we call EDSS, remain stable and they remain functional as long as possible. That is what I wanted to say.
Thank you, Dr. Shripad. So there are ongoing molecules for further research. I think there are ongoing trials for progressive MS as well. Drugs like BTK inhibitors are being seriously contemplated. Hopefully, the trials should finish this year. and we would have some more evidence. But there are hosts of drugs which are being tried from different biological pathways. So there are a couple of questions that have been generally asked from the diagnostic perspective. Like, for example, there was a question which was talking about that I was diagnosed with INO and I had a lesion in the pons and my oligoclonal bands is also positive. Should I be treated as a CIS and I should be started on treatment? So from the diagnostic perspective, once we diagnose the CIS conundrum, the RIS, CIS, RRMS, could you clarify what does that mean to us and how do we process that management in our clinic?
Sure, Rohit. I think that's highly, I would say, interesting whether the patient is well informed about being diagnosed with CIS or IAS. That gives a lot of insight into their knowledge of the whole thing. But as we have refined over the years now, I think although from the clinical standpoint or the diagnostic standpoint, calling it a CIS, RIS, or RIMS holds its importance, but our criteria have so refined now that even at a first attack, when you might so-called call it a CIS, first I'll just deal with CIS, that would in all likelihood turn out to have fulfill the criteria of a RRMS if we do all the tests, including an MRI with contrast. So if there's any kind of a contrast enhancement which is seen on the MRI, and or you also get an oligoclonal band which is positive on the CSF, that itself is an indicator which is an equivalent of a second attack and can be taken as a diagnostic criteria to fulfill the RRMS and hence should be treated. Very rarely, in fact, in our practice too, we find that the criteria for CIS, after including the other investigations, they do not get fulfilled. And in that case, the only other two things which we tell the patient, we counsel them that almost we are sure that this is MS. But if we are going to strictly go by the criteria, let's wait for another month or two and get another MRI. So if there's an increasing lesion load, that itself tells you there's either there are new lesions which come up or there are expanding lesions. That's clear-cut indication of dissemination in time. Or you wait for the next attack. So we should we can discuss it with the patient. How would they want it? If we want to stick to the criteria. The other part is RIS. So RIS has had an interesting evolution over the last few years now. Many years back, we were not sure what we were dealing with. And these are usually the conditions where somebody gets an MRI done for something unrelated. And in all commonality, it is headaches or somebody who gets a minor head injury who needs to get his just check up. If everything's wrong with the brain, they get an MRI done. But it's usually headaches which prompts MRI of the brain. And what you see is something very similar or just suggestive of demyelination or MS. So these are those patients who are in the preclinical stages. That's what we are now. It's been understood that MS basically is nothing but a manifestation of these lesions which cross a certain threshold. There is a reserve in the brain which does not allow symptoms to come up. So we are probably picking up patients who are in the spectrum of MS and will very soon manifest. And there is very robust data now or evidence whether we treat the RIS patients with some of the oral DMTs, they clearly have shown that these are patients. There is a clear reduction in the chances of them converting into MS. So that would mean that RIS should also be treated. And there are certain RIS patients who are at a greater risk. Those would primarily be the RIS, which has lesions, a large lesion load, enhancing lesions, and lesions in the brainstem and spinal cord. So if you have an OCB, which is positive. So if we have this combination of an RIS, we're getting lesions in the brainstem, cord, or enhancing lesions, especially if they oligoclonal band. So that is the reason we always insist that the CSF should always be done, because that really helps us as of our current understanding in improvising on our diagnosis and our prognosis. So if those are the cases, we can have a active discussion with the patient and kind of a shared decision making, as we call it, and start them on treatments, even if it is an RIS, considering that there is definitely a risk. It's no longer, I would say, anything not known, and there is a visible risk currently that RIS patients do have, and even they may be started treatment.
Thank you, Dheeraj, for enumerating it succinctly as to how do we make these decisions. And as you rightly said, that treatment paradigms have evolved over those years, and we really don't look at CIS like CIS. We look for evidences to suggest RRMS. Also, there is adequate data in the past about treating CIS who at least fulfills the criteria that it is looking like an MS related CIS. So thank you very much for that. I would ask one question to Dr. Tapas, that there is this concern by few of the patients in the clinic and on the question box also, is that they were on, let's say, one particular brand of dimethyl fumarate, and for some reason that's not available for them. I mean, the question is, should they, because obviously missing the dose is not a good thing, or missing the drug, can they shift to a similar drug from a different pharmaceutical brand? I mean, are there really concerns, and how should they navigate through that non-availability if it is there persistently and likely to be persistent?
Right. I mean, it's a very important question in the sense that we had these branded products earlier, and now we have got the generics, and the difference in price is quite a bit. So many of the patients, they ask me that if I go to this cheaper version, whether this is equally good as a branded product. Now, ideally, the generic drug should have the same kind of pharmacokinetics and efficacy as that of the branded product. But, all the trials have been done with these branded products. We do not have any trial with the generics. So that way we cannot say, but I leave it to the patient. If they can afford to continue with those products price-wise, I say, okay, you stick to one brand. If they say, well, it is not possible, I say, okay, there's generics are there, give it a try. I have seen that many of my patients who have been switched from the branded products to the generics, they are doing well so far. I mean, in real terms, over the last few years, I would say for the last 5-6 years or so, many of them have switched to the generic drugs. And I don't find a great difference in their course of illness. So this gives me more faith in our generics. So I will leave it to the patient rather. I mean, if they can afford to continue, or if they want to go for other things, okay. That's how we deal with this.
Yeah, I think that's an important perspective, that it's the comfort and the longevity of maintaining the therapy that is way more important than to be apprehensive. There would always be an apprehension with both the doctor as well as the patient when you are trying to move. And like someone had asked, like, I'm on a particular generic, it's not available, it's not likely to be available, what do I do? Though in that scenario also, rather than missing your medication, you can shift to another one. It's a bit of a concern, of course, but looking at the preparation of these drugs, which is likely to be similar. But one advice would be that don't keep on shifting back and forth for 1 month, 15 days. That may not be a great idea, because then it'll be more confusion. So if you feel that this particular one was not available and you need to move on to the next, and it is suiting you, so let move on, remain on that. Frequent changing will be uncertain to us as well. So that is something that you need to be careful about. The other thing is about a question related to Rauf. Would you like to take this question? Okay. Dr. Thomas, would you like to take this question? Are you available? Okay. Shruti, maybe you can take this question.
Rohit, I'm there. Rohit, I'm there. Rohit, I'm there. Sorry, it was taking time. Yeah.
Okay. So there is question about how efficacious is bone marrow transplant and should that be a good option for patients and how do we navigate through that decision?
Yeah, I think Rohit, you are the best person to answer bone marrow experience. But I'll tell the concept. Concept-wise, bone marrow transplantation is supposed to be a very good treatment because you completely reboot the immune system. But the issue with the bone marrow transplantation, what we face is that, the first is the cost. Then during the process, you have to be isolated for around 4 weeks. Then you may go for a severe immune suppression, the risk of infections, and there is a 1% risk of mortality. So, that mortality risk is coming down, but still there is a risk of mortality and serious infections. You have to be revaccinated again. So, and then also this bone marrow transplantation has to be done early in the illness. More late in the illness, it may not do any good help to you by doing the bone marrow. And then the experience of most of the MS physicians are not much with bone marrow. So in that way, we are tied up when to decide on bone marrow, but many times patients have agreed and we have discussed with our hematology team. And also fertility. You have to take your ovum and sperm and you have to do the banking for that because your all multiplying cells will be completely depleted by the bone marrow treatment. So there are other aspects to discuss like cost, infection, the chance of mortality, and also fertility. So these all comes, then it becomes a difficult decision for most people to take the decision on bone marrow. But theoretically, it's a good treatment to go, but you have so many associated risks associated with that. I think Rohit, you can add on that because I think your team had done bone marrow transplant for patients.
Yeah, so I think you pretty much highlighted all the points. So bone marrow transplant is definitely an important, I would say, second/third line treatment. And choices are made very specific to individualized decision making. Generally, people who have a very aggressive disease and failed at least more than 1 to 2, preferably 2 DMTs, because now we have effective DMTs which can curtail the aggressive disease also. And science has been looking into this specific question about comparing highly effective treatments to early bone marrow transplant as well, or moving to bone marrow transplant early. Yes, if you have a patient who is not doing well on more than 2 DMTs and you have tried a highly effective DMT, and it is definitely worth to discuss with the patient about the possibility of bone marrow transplant, because you don't want them to transition to increasing disability, at which point the bone marrow transplant may not be able to reverse, although can maintain, but may not be able to reverse the situation. So it is good to discuss and take a clear decision based on a shared decision making on the fact that you are able to accept the downside of bone marrow transplantation, risk of mortality and infections, and that needs to be very well informed to the patient and the family before they take up, and of course discussed internally with the bone marrow transplant team as to how they perceive the patient's general condition and comorbidity. So that is a specific thing that needs to be done in the clinic in a more detailed fashion. There's one more question which is there from an audience about bladder, and I think that's an important point. The question is about taking time to clear a desire to put pressure to expel urine. So I would request Dr. Shruti, if you can highlight about the bladder issue and what are the ways we manage the usual bladder complaints in subjects with multiple sclerosis.
Thank you, Dr. Rohit. So bladder issues are quite common in MS patients, and it can take the form of both problems with storing the urine and problems with passing urine or voiding the urine. Sometimes patients have issues of holding urine, so they have to pass even before they reach, and they have what we call as accidents. And at times they take a long time to start urinating, or when they do start, it comes at spurts or it's a low, poor stream. And they often have issues where they are not able to expel the urine completely, and some amount of urine remains in the bladder. And that retained urine can cause infections repeatedly and can also lead on to some pressure onto the kidneys and the upper part of the renal system. So it is quite important, therefore, to be able to control the bladder problems. The treatment will actually depend upon what kind of problem is that. So if it is a storage problem, in the sense that if the problem is with holding the urine, it passes without your own knowledge. Generally, what we ask the persons to do is keep a diary of how often they drink and how much of urine they manage to micturate at a given point. So that can be measured, and it can be seen if there are certain life habits which are interfering with it. Sometimes too much of tea, too much of coffee, or even just too much of water intake beyond a particular time can interfere with this holding back urine. And that part should be corrected first. After that, if that is all right, they need to get an ultrasound to see if there is any bladder is left, urine is left behind after they micturate, and that is also safe. It is okay to start certain medicines which can relax the bladder, and there are quite effective medicines which are available. And the type of medicine should be chosen based on whether there are any other comorbidities, such as depression, or if they have any cognitive problems. Those things matter when the medicine is started. That is one way of treating an overactive bladder, or a bladder where the problem is storage. But if the problem is actually micturating, that the problem is with the voiding itself, then again the first thing is to identify what are the contributing factors. Sometimes the low muscle tone, the fact that they hold the urine for a long time, those factors may be responsible. So a timed voiding can be helpful. And medicines are far less effective if there is a problem with voiding. There are a few medicines such as alpha blockers which can be used. But other than that, you may have to discuss with your physiotherapist or the rehab team, or with a urologist, regarding whether intermittent self-catheterization or other physical methods can be used to avoid infections. So repeated infections is again another concern, and if there are more than 2 or 3 infections per year, that is another reason to see what is the contributing factor and treat accordingly. So any bladder symptom in MS needs proper care, and some of them can be managed with lifestyle modifications and physical measures. Some of them can be well managed with medical therapy, and there are even surgical methods such as intervention methods as Botox injection and other surgical methods which can be used in bladder problems. So please do meet a neurologist, and if referred by them, to a urologist or a physical medicine consultant.
Thank you, Shruti. Just to add in here, there's a specific question about I can hold, but problem to pass. So this symptom is basically hesitancy that you are, you are having. That means that you have the desire, but the bladder contracts, but your sphincter, which has to open up to release, doesn't happen. That's typically called retrusor sphincter dysenergia. And for these patients, we can give drugs where we can help the sphincter to open. Like if you see elderly people who have prostate issues, they are given drugs like, Urimax or others which help in opening the sphincter. But you need to be very sure that you don't have desire to void fast, because when we try to open the sphincter, then you may have paradoxically, dribbling or running very quickly to find a washroom. But you need to discuss it with your doctor. And for both, as Shruti said, if you are too much in urgency, we relax the bladder. If you are having difficulty in passing urine, then we can help you with specific drugs to help either contract your bladder or help, open your sphincter, which helps you maintain the fact that you don't void unnecessarily without control. So all that is possible. So one last question, Dr. Gorti, is about someone asking about management of pain, which is typical like trigeminal neuralgia, and who has someone been on carbamazepine and dose is high. How can we manage with what are the other methods that we can manage trigeminal neuralgia?
Yeah, trigeminal neuralgia can be managed with narrow blocks, botulinum toxin injection in the distribution of the which trigeminal nerve is affected, is ophthalmic mandibular. That's how we do usually, and we also inject into the trigeminal ganglion, the botulinum toxin. So, and these are the methods, and you can increase the dose. And a dose of carbamazepine is very high. Usually, the people tolerate up to 1400 milligrams. But the other methods which I have used in nerve blocks and as well as botulinum toxin injections. Rohit, before I just wanted to tell one thing, because many people have said that the treatment for MS is lifelong. And there are two things which I want to tell. Even Shoemaker said after 55 years, MS is not likely to be there. The second is there are studies which have 5-year follow-up of the people who never had a relapse. They stopped the drugs, and at least 80% did not have any relapse. So there's some study, there's some hope that we may get rid of medicines, and mostly in our experience also people don't take treatment beyond 2 years if they don't have relapse. But this is what I want to tell, that people should not go away that there is no treatment, we have to lifelong condemned for treatment. No, that's not the case. There are studies going on, and there is a ray of hope.
Thank you very much. There was someone who had asked about what is ongoing in India for research. You're talking more from the West. So, so we understand that most of the previous trials and medications have been researched from the West, because it require these research started from those countries where MS is very high in incidence and prevalence, and that's what made them do a lot of research for medications that would help. And many of these researchers do have India, as many centers from India have participated. It's not that they are only centric to the Western data, but a lot of these trials happen with patients from India as well. So it is I would say a lot of people across the world are a part of these trials, a lot of countries. So we do have participation. But yes, because the research started way back in those countries due to high volume, their pharmaceutical companies have specifically directed them towards finding new molecules. But the good thing is that now Indian companies also manufacture at least the same salts, generic salts, which are much, much cheaper. And we are also paving way for research. One of the ways that we're doing that is having multiple centers in the country which have joined, funded by the Indian Council of Medical Research, to develop a national MS registry, where I believe many of you who are part of different institutes where you are showing, which colleagues are there on the dais right now, may have been, are probably a part of that registry where data is being collected. And that data will help us understand how our patients are doing, whether they are behaving the same way like the Western. And we are also conducting internal researches on simple things that we want to answer from that information that you kindly participate and give it to us. And we will be answering those questions that will help our patients to navigate through MS. A small strip of that, I would just like to share to you what we call the Indian MS and Allied Disorders Registry and Network, which is currently funded, and a lot of us are a part of this. This aims to collect information on very different concepts, and we will be able to answer questions to most of you as our research progresses. So this is just to tell you that we are also actively doing, yes, we are not researching new molecules as of current, but we're looking at different components to understand how our disease is behaving and how it is going to, because at least your questions will be able to be answered better if we understand how our patients do on a long-term follow-up. So that's from all of us. And I think we've taken most of the questions from the attendees. And I will now hand over Netra for her comments and request Dr. Debashish to close. So Netra, please, over to you.
Thank you, Rohit. Thanks to all the panelists. Thanks to all the attendees for having joined this program and being there till the end of this program, and coming forth with so much important questions, especially the real time as to what you're facing. And I think all the panelists helped in dissecting it out and giving an appropriate answer. So thanks to the attendees for coming to this show. I thank the panelists for joining in, and especially many of them are in their busy OPD. Still, they could make it on this World MS Day and give us all their inputs. Thanks to Rohit who has literally driven this World MS Day webinar and brought it to all of you. I also should thank the team from the back end, Asmita and Mansi, Bhavesh, who have, all of them have done a great job. And we are here. Thank you. I think Dr. Debashish went away at the last moment. Also would like to thank IAN for giving us this platform so that we could celebrate this World MS Day among all the people who are for MS, doctors who want to make the people with MS better and to show our solidarity with all of you. Thanks. Thank you, one and all. Dr. Rohit, Dr. Debashish is not there. You want to tell something and then end it?
No, I think you've already spoken. So, I mean, I will only thank my Indian Academy of Neurology, its members, Professor B.S. Singhal, to have been very kind to have joined in the beginning. All my colleagues from different institutions who have been involved in care of MS patients, and especially, and of course, my IN team for helping organize everything, Mansi and Asmita at the very last minute, and pushing them to, do things. And last but not the least, I think I must thank all the attendees who have taken out time and felt us worthy of discussing their questions and interaction. We would have been, if it would have been possible, it would have been more, interactive if we could see them online and they could see us. But nevertheless, I think we've tried to cover most of these questions. I will only end by the note that when you hear about this diagnosis, don't just feel that something, really has hit you, because that's something which happens to the majority of our patients. And they read a lot and then they come with, feeling that why I was the one who had this disease. But science has moved fast, and it is moving very, very fast, I would say, in these disorders. So don't feel let down, and I think remain positive. And we are there to support you. There are a lot of doctors in India who work on MS, and the science is progressing. A lot of medications are available, and we hope and we think that most of our patients will remain very, very stable for years. So thank you very much on that note, and we hope to meet you next year again on the MS Day. But there was a request from one of the audience that if we could have these meetings maybe once in 6 months. And I think as a mandate from IN and as a mandate of the subsection, we potentially can do that. And I think I promised that audience that we will do that every 6 months. So let's have it for them. Thank you very much.
Thank
Okay,
you.
thank you.
Good
Thank
night.
you, everyone.
Good
Bye. Bye.
Thank you, Rohit.
Thank you.
Wonderful job. Thank you. Bye.
Thank you. Bye. Thank you, everyone.
Bye.
Thank you.
Thank you. Thank you all. Thank you. Thank you.
Great meeting, Rohit. Thank you
Thank
very
you.
much.
Bye. Bye, Nick.
Thanks.
Thank
Bye.
you,
Thanks.
Dheeraj.
Thanks. Thank you all. Thank you all. Take care. Bye. Good night.